Assalamu alaikum dear doctors. In this video I am discussing a video station from these pictures. So first, how can we describe this video? So that is, I can see a child maybe 5 years appears well or ill, very important, which is mentioning average or small for age. However, I want to plot him on appropriate centiles. He is in a hospital setting, not dysmorphic, not attached to any device. There's a temperature chart showing spikes of fever between n-degree. I can see the right leg show redness and hyperemia. The child is sitting in the bed, not crying, but when someone tries to move him, he starts crying as if in pain. So this is a case of monoarthritis with cellulitis. What is the differential diagnosis of this video? So the differential diagnosis can be osteomyelitis, cellulitis, septic arthritis if in the joint, non-accidental injury, trauma or fractures, acute attack of any JIA, SLE, other collagen disease, malignancy either primary tumor of the bone or leukemia, Lyme disease, hematological disease like sickle cell anemia, hemophilia if boy, plus in the joint. Now, what are the history you will ask for this patient? The history I would like to ask, number 1, onset, course and durations, FWASL, we know that fever, weight concern, activity, sleep, and any lump, lymph node. Then musculoskeletal system, pain, tenderness, abnormal gait, abnormal movements, any rash, eye, hair, face. Any pallor, weight loss, abdominal pain, swelling in the body or bruises, any history of trauma, any history of travel. What about the number of diapers changing during the day and his feeding, any chronic illness, any medications he is taken, any bleeding from any body orifices, any previous hospitalizations, is the family registered to the social worker. Now, next question, what the examination you would like to do? So, I'd like to do ABC first, airway, breathing, circulations, vitals, very important, and also check the hydration status, musculoskeletal system examinations for hotness, tenderness, range of movement for any limitations, examination of the skin for rashes, bruises or petechiae, examination of the eye, abdominal examination for hepatosplenomegaly and lymphadenopathy. Now, what is the management plan? So, management plan is after involving my senior, my consultant, orthopedic surgeon, interventional radiologist and anesthesia specialist if needed. Then I will run some tests. These are number 1, septic screen. I do the full blood count, ESR, CRP, blood culture if immunocompromised, others culture to tuberculosis, fastidious organisms, anaerobes and fungi. Number 2, the radiology. These are X-ray, entry, posterior and lateral view if normal result. So MRI either for the joint or whole body in case of possible multifocal infections. Number 3, if cardiac murmur or multifocal staphylococcus aureus, ECCHO. Now, what is the treatment of this patient? That is, the immediate treatment is that I will admit that admission, keep the patient NPO, IV fluids, painkiller up to IV morphine. Then give bed rest, splintage, leg elevation, plaster back slab for peripheral joints. Antibiotics we give, number 1, with severe sepsis and organ dysfunction, hypotension, oxygen requirement, GCS less than 12, platelets less than 80, creatinine 2 normal, abnormal liver function test. We give the cefotaxime. Number 2, if no organ dysfunction, then less than 3 months we give cefotaxime or ceftriaxone. 3 months to 5 years we give the cefuroxime, and more than 5 years we give the flucloxacillin. Rash, cefuroxime or ceftriaxone, history of anaphylaxis or high risk MRSA, high dose clindamycin and surgery. Number 2, subsequent management, that is A, uncomplicated osteomyelitis or septic arthritis. We give the, if IV antibiotics started within the first 24 hours with good clinical response, discuss with the consultant to change to oral antibiotic after 72 hours. If recovery of the joint movement, no fever, WBC count more than 11, CRP and ESR falling in 2 specimens more than 24 hours apart. Then if no organism is identified, give the amoxiclav. If organism identified, narrow spectrum antibiotic with good bone penetrations. If staphylococcus aureus, give flucloxacillin high dose. If penicillin allergy, oral clindamycin. Duration of treatment is 3 to 4 weeks with except in hip for 6 weeks. Number 2, established osteomyelitis. For established osteomyelitis, after 24 hours from the onset or partial treatment, formal debridement with Hickman line insertions, antibiotic IV as the above, the switch to oral after 14 days if no fever, pain free and CRP less than 20. Then oral antibiotic till all inflammatory marker is normal and radiological evidence of healing. Number C, deteriorating or failure to improve within 48 hours. Then we inform the orthopedic consultant for drainage of the pus. Review culture results. Discuss with consultant microbiologist and pediatrician to repeat the cultures. Exclude the other DD. Number D, how can monitoring the treatment? Monitoring treatment is that peripheral color, warmth, movement of the limb hourly in the first 4 hours, then every 4 hours in the second 24 hours. vitals every 4 hours. So this is all about this video station. Please do subscribe and share MRCPCH with Dr. Emma Choudhury. Thank you.